Good evening. Assalamu alaikum to everyone. And thank you so much for joining for the next in series of the APPNA MERIT Healthcare Research and Innovation Landscape in Pakistan webinar. And we are today talking about the embracing disruption using simulation to demonstrate patient safety and quality improvement. And our speaker today is Dr. JABEEN FAYYAZ, who has joined SimKids in 2016, which is part of the University of Toronto, and she is the SimKids Medical Director Assistant. She is a fellow and is currently a staff physician and assistant professor at University of Toronto. She graduated from Pakistan and worked as a pediatric emergency physician faculty at Khan University for 5 years. She was among the few leaders in Pakistan with the EM specialty recognized by the College of Physicians and Surgeons of Pakistan in 2011. Later on, she worked at the Sultan Qaboos University Hospital for 3 years and led the implementation of the Canadian triage and acute scale, followed by a quality improvement. She has Lean Sigma methodology that she has learned, and in 2015, she started her fellowship at SimKids, followed by 1 year simulation fellowship in 2018. In 2018, she completed her master's degree and then followed by PhD in simulation from the MGH IHP, which is an affiliate of Harvard. In addition to FCPS, she is also the resuscitation lead for the contemporary-based medical education program. And I can go on and on about talking with about Dr. JABEEN, who has multiple achievements in the field related to pediatric emergency. But at this point, I would request Dr. JABEEN FAYYAZ to take it over and inform us about simulation and maybe some of the pediatric emergency. So welcome. Thank you so much, Dr. JABEEN. It's over to you.
Thank you so much, Sarfaraz, for such a kind introduction. I'm really humbled, and thank you so much, Dr. Uzair, for providing me this opportunity, the whole leadership of APPNA. I'm hoping today is to provide a little bit of glimpses of what simulation is and what simulation is actually capable of. I am completely admitting that there must be maybe a lot of knowledge coming to your way. Do not get overwhelmed by it. It is just to show you where are the opportunity, and then definitely we will create something ongoing for every one of us. So it is just to show you a couple of the things which we are able to achieve and we can achieve together, even in low resources. Before Hello, can everybody hear me? I know I got disconnected for a minute.
Yes,
we can hear you now.
Yeah, perfect, great. So what I'm trying to say that today I'm going to talk about a lot of different.
Please, excuse me, reshare your slides.
Yeah, I'm resharing my slide. Thanks, Walid. I appreciate announcing it, and that's what I am doing right now. You can see my slides, and it's appearing fine.
Yes.
Perfect, great. Please continue posting your questions, queries in the chat, and I will try my best to take it at the end as much as possible. But there will be my contact information at the end, and please feel free to connect if you feel like that something is relevant to your setting or you want to know something more. So I have chosen to talk about the utilization of simulation beyond teaching and learning. What I thought and why I chose this topic is there's a huge misnomer that simulation is only about teaching advanced life support courses, like, for example, ACLS, Pediatric Advanced Life Support, BLS. It is much more than that. And then we as an educationist always think that we are only contributing in the education or teaching and learning of our learners. Those learners can be medical students, can be our resident, postgraduate, and we have a little role in clinical, in affecting the clinical outcomes or improving the quality of care that we provide to our patient. So that is why the education-based research is not given that due respect, I would say. So I would try to show you that how any kind of education, especially simulation-based education, can be directly linked for improving the patient safety, quality of care we provide to our patients, which is kind of an ultimate goal. That's why we become physicians, and that is where our passion lies. I do not have any disclosure or conflict of interest to disclose. What I try to do today are talk about three things: that how can we utilize simulation beyond conventional teaching and learning? What is the role of simulation in quality improvement and patient safety? And how we can use simulation for outreach and capacity building in a resource, I would say in a less resources, because this is also a misnomer that being me sitting in North America Sim Center, I have a lot of resources. That's why I can talk or do anything, but that's not the case. We still can do a lot, even in low resources, which we are doing it for last many years. If I talk about my personal and professional identity, as Dr. Sarfraz was telling, I worked in Pakistan for almost 13 years, starting from my clinical clerkship up till my faculty position, initially at Aga Khan University Hospital, Civil Hospital, where I did my house job, I did my residency program, and then I joined Aga Khan University Hospital and worked as a faculty there for a few years. Then I joined the Sultan Qaboos University Hospital Emergency Department, and then later come to SimKids. So why it is important? Because by doing that, I got a chance not only to see the whole paradigm of public and private sector hospitals in Pakistan, but also get exposed to multiple healthcare settings in different countries and in different culture, which I believe has influenced me in many positive ways, and it made me more humbled, and it made me more aware that how much we should be aware about the resources and its utilization. With this little bit of context, I would go and straight away dive into of what is simulation, which you all are here to learn about. So I would say that simulation is another technique, and I really like this sentence, that it is not a technology. We, most of the time as educators or as physicians, get into this mindset that it is a technology, and you have to bring up very costly or very hi-fi technology to bring simulations into your clinical setting or into your educational setting. So simulation is not a technology. It is a technique to replace or amplify real experiences with guided experience that evoke or replicate substantial aspect of the real world in a fully interactive manner. So it is just to mitigate or make your learners learn something in a way which is not your actual clinical environment, but you try to make it as realistic as possible. And one of the common example, and please forgive me, most of the examples will be acute care or from pediatric emergency medicine, because now for last 18 years, I'm just doing PAM. So that is why this is my kind of bias, that most of my examples will be pediatric emergency medicine, but if you provide me context, I can tell you how you can utilize in your own setting. That could be basic sciences, non-acute clinic setting. So for example, how I learned to intubate a neonate is, unfortunately, my first shift of the house job, where a preterm baby passed away, did not able to survive, and then and I was in a kind of grief, and what I was told that to learn to intubate on that patient. So it is, that process has its own pros and cons, but think of if we have to make our learner learn on actual patients, for acute care things especially, this is a scenario that rather than grieving the death or taking care of end-of-life care, I'm just focused on learning how to intubate on that dead baby. So the simulation provides you opportunity that you do not have to wait for that stressful event to happen. You can even make your learner learn to intubate, learn to pass IV line, learn to pass IO or get an IO access and many other procedures and many other emergency situations without them being in that situation in actual environment. If we talk about the simulation-based learning activity is structured activities that represent actual or potential situations in education and practice. So it brings the situation and the context together. For example, you can think of like physiology not being taught as physiology, rather than taking a shock scenario and then bringing the physiology student, the pharmacology student, the pathology student, and the student from medicine. They can sit together and they can learn about different aspects of shock from their own perspective and contribute to each other learning. I wish we will be able to do that, because since still we have done our medical school and start our house job, we are still, or maybe in the final year when we started our clinical rotations, we always question each other. Why I have to learn all this anatomy? Why I have to learn or remember or memorize all these medication, their side effect, their mode of action? Because I was not provided the context that what I'm going to learn, I'm going to apply for patients, and this will be the benefit, which is the ultimate benefit or aim why I was inclined to become a physician. So same-wise, these activities, which are simulation-based activities, learning activities, allow the participant to develop or enhance their knowledge, skills, and attitudes, and also allow them to analyze and respond to realistic situation in a safe learning environment where they know they can learn by doing mistakes. Nobody of us is perfect. Even now, after 18 years of PEM, I still struggle with certain situations, and then I learn from those situations and improvise when I have to go through those situations from next time. So think about your learners, which, like when I did my house job, I was first shift alone with a nurse, and I proudly say up till now, most of my learning about procedures and all those things happen because I have amazing nurses with me who teach me how to pass cannula in a baby, how to do a umbilical vein catheterization in a baby, and help me in doing exchange transfusion. So if we look at the paradigm or history going back, simulation-based learning. So simulation-based learning is now well known in the medicine world to provide training not only for cognitive skills, but also technical skills as well as behavioral skill, because the simulation setting is felt to provide them an opportunity which is realistic and safe. And then by adding on different components of fidelity, which is kind of realism by technology, that they can learn about medical knowledge, but also learn about teamwork, communication, and system improvement. Now, whoever is working clinically, we all know that as a physician, we cannot work on our own, especially in an academic setting or in a hospital setting. We need our nurses, we need our clerk, we need our social worker, we need our airway, like a respiratory therapist, or many, many other people who we have to coordinate. So which is very important. And by simulation, you get a chance not only talk about the technical skills, knowledge, but also about the non-technical skills. And if you do that, you will identify your system problem, and then you can utilize it for the improvement of it. So if you look very, very old, as most of you will be aware that a lot of our quality processes, a lot of our learning come through the aviation or from the military industry. Likewise, simulation has got its way through the aviation industry. And what is showing here in the picture is 1910, where the first pilot in simulator was developed, and you can see how novice it was. And then this is 1929, a simulator blue box kind of plane was invented for them to learn how to fly. And now they have this virtual reality whole simulation where they learn about different aspects of aviation, and then you can see that how much they pay attention on their problem solving, on any event debriefing, etc. So there's a huge progression has happened, which is not a long ago. I would say it is only like 100 year, and in 100 year we have been from a wooden simulator up till virtual reality, and now technology boom is there, and you must have heard about artificial intelligence and many augmented reality and many other forms of technology which is coming, and it is going to be in the field for many years. If we talk about our medical world, the first simulator or simulation related activity was adopted in 1968, where a physician named Michael Gordon in the University of Miami simulated the cardiology patient simulator and make the learners learn about it. So it's 1960, and in 1970, the simulation, since 1970, the simulation is now widely being used in all the health, like all industries, including healthcare and many other industry. If you look at the utilization of simulation-based learning, we think that with simulation, it is only lower level Kirkpatrick. If you have been in the education a little bit, you know this is a Kirkpatrick level, where level 1 is only reaction and level 4 is the actual results. And I can give you an example. For example, I introduce a simulation-based course for neonatal resuscitation. Or you can say for intubation. So first level is, how do you feel about it? Did you like the course? Did it make you learn more better? So these are level 1 and level 2. Impacted, that because of this simulation, are you able to manage the neonatal resuscitation in a better way, that their behavior changes? And then the result, or level 4, is whether my neonatal resuscitation outcome before that course over 1 year is like once I implemented this course is better than before and after. So this is like actual patient level results that you can find. So if you look at all the Kirkpatrick level, the simulation is basically fit. You can go from reaction to results very easily because it has the capacity. You are just mimicking all the real life clinical situations as a simulation. Those who are interested, I would like to tell them that there is a whole huge theory, science behind it. And this is a Society of Simulation in Healthcare has released, this is a second updated version. You can see 2.1 version, second edition of the Healthcare Simulation Dictionary, where you want to find out their terminologies and their actual meaning. So there's a barcode. You are happy. I'm very, like if you're willing to have this downloaded, please feel free to do that. As a simulationist, we all have one version or one copy onto our every device, laptop, desktop, because there are so many terminologies that you need to know what does it mean so that it will make your communication better. Then there is this in Excel, which is another society for simulation who have released the standards of healthcare simulation. And this is the barcode which will take you to the website where all these standards of healthcare simulation of best practices are there. And there are 12 standards which include your different components, and different components are facilitation of simulation, pre-briefing of simulation, debriefing of simulation, the development of scenario, what does the interprofessional education mean in simulation, and many more, and how would you do evaluation when you are doing a simulation-based education. So this is a little bit to give you a little knowledge that what actually simulation is before diving into its utilization. So what I want to tell you, like I'm a director of SimKids, which is a SickKids Simulation Center, and anybody who is in Canada or planning to visit to Canada, please let me know, and I'm happy to take you around and show our Sim Center. And I'm not showing it for the sake of that what it is. It is just to tell you what capabilities we do have at our Sim Center. This Sim Center we just got 2 weeks ago in November 7th or 10th. But before that, our Sim Center was only 1,600 square foot space with only 2 rooms. And yearly, we have almost 30,000 plus learner that go through those 2 spaces. So what I'm trying to say here, that this is again a huge misconception that you can do Sim Center or a lot of simulations only if you have a big Sim Center. If you have a hi-fi costly technology, this is not the case. As I said, if you look into the definition of simulation, simulation is not about technology. It is just a technique, and many, many big institutes or big centers, for example, Children Boston, the Children Hospital for Philadelphia, and Norton Children Hospital in Louisville, they do not have any space for sim, and they all do simulation in situ in their actual spaces or the lecture halls or conference rooms which are available. So coming back to our Sim Center, which we really got it 2 weeks back, it is now a very fancy 11,500 square foot simulation center with multiple rooms, which include multi-purpose room, specialty spaces, high-tech fidelity room, debrief room, and some assessment room for OSCE. So these are some of the pictures of our rooms, which you can see that include multi-purpose room, etc. These are some of our patient simulator that are available in our Sim Center. This is one of our high fidelity room. We do have multiple task trainer. The first one is the chest tube. The second one, this one is a IO, which is a humeral IO. And then there are multiple for other thing, like I think this one is either peritoneal or something like that, but this is the tracheostomy one. And then we do have 3D printing capability available, and we are doing, oh, sorry, I'm so sorry. I went a little bit faster. So we do have our Sim Center does have a 3D printing capabilities, so which is gaining a lot of momentum into the simulation world. And with the 3D printing, I'm sorry, it's just going. Yeah, this is 3D. Why 3D printing slide is not coming? Yeah, this is a 3D printing slide. So we do have a 3D printing printer, which can generate a lot of equipment or task trainer at a very, very low cost. And if you read about 3D printing, there's a huge literature that is coming up, and it is not very old. It is in the last 10 years. And we do develop these 3D printing models for community EDs, for some of our surgical specialties. You want to do a lot of procedures, and cost is a problem, because even if you buy a leg for IO, it is much more costlier, rather than you can create a 3D printing humerus, which you can create in $1 or $2. So this is how the 3D printing is being utilized. So now coming to the first part, which is simulation beyond conventional teaching and learning. And the first thing which I want to mention is our team training in situ. And these team training in situs are interprofessional. And what is I meant by interprofessional is that we do have every member of the team, which is actually working in the emergency department, participate in it. That will include our nurses, that will include our clerk. If social worker, then social worker. If we have learners like medical student, residents, faculty, all participate into it. And the simulation which are in situ are the simulation that are physically integrated into the clinical environment. And that clinical environment can be any. It could be your clinic environment, it can be your floor environment, it can be your OR if you are a surgeon or if you are an anesthetist who are working in the OR. So any training that happens in your actual environment are called team training in situ. And there's a huge shift of simulation-based activities to happen outside the simulation center and to actually happen in situ, because by doing it, you will actually identify what are the problems which my clinical environment have. So I will talk about it, that how it can identify a couple of things. So if we look at the evidence why how team training in situ are important, so it is fascinating to hear that it provide a level 4 outcomes, and how these are some of the literature, and it is not a recent literature, it is from 2011. So you can imagine for last 12 years people are working on it, and they have shown that sim-based mock cohorts in their actual environment improve the pediatric cardiac arrest survival. It improved the core team performance, it improved their communication, and hence improved the patient survival outcomes. It also, when it happens in ICU cardiac arrest debriefing improves the survival outcome. And then improved outcome from cardiac arrest in frequent in situ simulation in many institutions that have happened. And if you look at the 2020 PALS guideline, they are recommending to every institute to have in situ simulation or some sort of simulation-based program implementing into your spaces to improve the learning, to improve the teaching, and to improve the outcomes of the cardiac arrest patient. Let me share some of the experience at SimKids. So we have introduced the unannounced in situ mock courts in June 2011. They usually happen 3 times a month, and we do have nurse educator and MD educator who lead those scenarios. This is like before starting that, we did a whole education session for the whole department that include the crisis resource management principles, the PALS guideline, the auditing of the gaps, closed loop communication, etc. was checked upon. A huge amount of work has been done for need assessment. And then the cases which were come up are these cases. And it is kind of a continuum basis. It keep on evolving. And if anything that serious safety event happen, if anything being notified to M&M committee, if any other problem happen, they will notify us and we try to incorporate it into team training in situ. So after each session, during the session, each case has a case specific checklist, which is completed by a MD simulation educator and a nurse simulation educator. This is a checklist which is showing up right now in front of you for the septic shock. And we do look at the team score. Team score is a score with validity evidence about the non-technical skill, for example, leadership, communication. So we also look for those, the data for those outcomes as well. And then we check the inter-rater reliability as well as we use it for a system process improvement. So the system process improvement example is this paper, which is published by my immediate fellowship supervisor, Jonathan Perry. And the barcode is there if you want to download this paper. And he utilized the use of statistical process control chart, which is a well-known quality improvement process to evaluate the interprofessional education sessions, which are embedded into our emergency department and what was the impact. So you can see here, there is 2 graphs, and then this is the upper red line is the upper limit, which shows that anything going above is showing improvement. It is very much clear here, more clear, because I'm not going into detail as I have to show you a couple of more things. So in a glance, what you need to understand that if you look here, this part, which is in circle, have shown above the midline or above the mean, which shows that implementation of such programs have led to better better communication, better leadership. So improvement in the non-technical, and then more in correct action on the case specific checklist. Although one can argue that it is in a simulation session, but then those simulations are actually happening in the clinical environment with the teams who actually perform are going to perform the similar case when an actual patient will arrive. So that is why you can correlate that improvement in this situation will translate into the improvement in the patient outcome. Then we do have trauma team training which the focus is like we all know that as a pediatrician, we are very less exposed to trauma. A lot of traumas either go to orthopedic, either go to adult emergency medicine, and still till last 4 years or 5 years, it's still the team leader for trauma were the general surgeon. But there's a shift happen, and then now at our emergency department and in many other emergency departments, which I know at least in the countries which I'm working, that it is the pediatricians or pediatric emergency medicine people who take a lead in trauma. So because of that gap, I also myself not trained in trauma. So I feel because of this transition of the role, they started the trauma team training inside to mega T3s where multiple trauma come at the same time, and code oranges when there's a disaster call. For example, why we started that, there was a school bus that gets set on fire, or there's some accident happen, and suddenly we got 12 kids at the same time, and we were not ready. So that's why they requested, the trauma leadership requested that can we develop something like Code Orange so that we as a department and we as a hospital are more ready to manage and be prepared for such cases. So you can see some of the pictures of our Mega T3 and Code Orange, and you can see how many people are involved, which are the participant or learners and the facilitator. So I'm sorry for that. I know you won't be able to hear anything. It is just to show you that how much chaotic this whole environment, which is happening in the actual patient care area. So these are all clips from our actual emergency department where they are managing or running these traumas. And you can see there's a trauma team training checklist, which has all the components which the teams need to be aware, and it is filled and then debrief later on. This is a team score, which I was talking about, and it is for the non-technical skills. I would like to tell everybody that it's not only that the simulation happened and then it's all finished. There's a huge analysis happen after the sims, and all the recommendations, including the action items, which comes out as a result of all these simulation-based teaching and learning activities, goes to the leadership, and they make some plannings and action items and forward it to different leadership. For example, if an intervention is suggested that is an educational intervention, that we found that there's a lack of knowledge about the hemorrhage protocol, then the order sets or hemorrhage protocol is created. But if there's a problem in executing that protocol, then there are system related or quality related process need to be figured out. So it will goes to the quality and safety committee and team. This is how the knowledge or the teaching and learning session you are doing using simulation is going to different stakeholders, and then it is getting translated into actual clinical environment and resulting in patient improvement. This is the same task. The second part, which I want to tell you about, is competency-based medical education, which is for faculty and fellows. And the concept comes back that we have a lot of emphasis on competency-based medical education for our learners, including our residents, our medical students. But once we become faculty, nobody pay attention that are we up to the skill? I learned to intubate as a direct laryngoscopy, but now no more it is a standard of care. Now video laryngoscopy is a standard of care, but I never been trained to that. So how I ensure that I'm learning the new skills, and then once you become resident or faculty, how many times you perform the procedures. We all are aware, I haven't intubated in last 2 years, or I haven't passed cannula in last 4 years, because it is either my fellow, either my nurses, or somebody else do that, and I supervise them. If somebody ask me to do, I will do it, but my skills are not up till mark. And same is true to lead a code, to run some stressful situation. So the concept is, from the team training inside too, we realize that even there are gaps in the knowledge of the faculty member. So we implemented a very unique competency-based medical education for the faculty as well as fellows, where it is 4 days in a year. Full day include resuscitation, point of care ultrasound, and the procedural skills, where every faculty has to go through it once, not every time, like 4 times in a year. One time they will do resuscitation, one time they do procedure. And half of the faculty become the facilitators and half of the faculty become learner. And it provides such a rich learning experience because you are learning from your colleagues and from your peers, and it is giving you such a rich opportunity to learn. And the end result or outcome is, it doesn't matter whether JABEEN is on call or one of my colleagues is on call. The patient which is coming to the ED is getting the same care and the same standard of care. So I do not have to rely that who is on call, so I will take the patient when physician X is on call, because I know that person has more skills than physician Y. So this is the example of our the rota for our CBME. We develop pre-reading learning modules on gaming, on the concept of gaming simulation, for which we are using an affinity learning platform. And you can see all these modules are present for the faculty and fellow to go through all these modules, do some of the tasks, and they have to submit the completed report of all these modules before coming to the skill day or the resuscitation day. And on the day of their CBME, this is the same kind of concept of checklist which need to be filled out. And interestingly, we do involve our nurse educator or respiratory therapist, depending upon what scenario is. And we do encourage the interprofessional learning, and that need to be two-way, which is like far missing from the Pakistani paradigm, that there's still, this is concept, doctors are doctors and nurses are nurses. It's not that they are learning or doing something together, which need a huge kind of our efforts to bring the nurses on the same page as well. This is again the same. And these are the 2 papers which I did it to do through doing my fellowship, simulation fellowship. Jonathan Parry was the first author. And these are 2 papers. The first paper is about the development and implementation of this program. And the second paper was about the impact and effectiveness of this mandatory competency-based simulation program. If anybody interested, Dr. Uzair will tell me. I will share all these resources because I know it is very difficult to get the hold of all the information which I'm just putting it right now to learn and to know about all this. It is just like I'm giving you a glimpse that what are the possibilities, so and what you can think when you think about simulation. After doing this simulation utilization beyond conventional teaching and learning, the second part which I want to talk about is quality improvement and patient safety. In the quality improvement and patient safety, the first component is latent safety threats. Latent safety threats are conditions or factors within the system that are present. You are not aware of them, but they are present, and they haven't caused harm to your patient. But if you have heard about the Swiss cheese model of quality improvement and patient safety, where they are aligned, there are different slices with different holes in it, and they are aligned one after the other. And when all the holes get aligned, then it only reaches to the patient. So that is the concept of latent safety threats, that they are passive, they are still in their environment, but you are not aware of it. So that is how you can utilize simulation to find out latent safety threats and to work on or find out various factors which are called as human factors. And human factor is a scientific discipline which is concerned with the understanding of interaction among humans and other element of the system. And there's a huge debate or boom of system science thinking, human design thinking, human factor in hospital environment, and people are using more and more as simulation to utilize and to test those systems. So that is why I bring this human factor. And one of the model which is very popular is the STEEPS model, which stand for System Engineering Initiative for Patient Safety, and it helps identify and analyze the various elements that influence the performance of individuals and team within the healthcare system. Because as you know, even if you have to give order IV ceftriaxone for the patient, how many steps does it have? You have to decide that whether ceftriaxone is the right medication for this patient or not. Then you will write down an order of IV ceftriaxone, 100 or 50 milligram per kg per dose. And in pediatric, you have to calculate the dose as per the weight. Once you put the order, the nurse will read that order, then pair the medicine, then deliver the medicine, then chart it that she has given, and then you will go back and see whether that antibiotic has given or not. Such a simple process like ordering and giving antibiotic has so many processes involved, and anything can go wrong here. So you can imagine how important it is to look at the system, how your systems are working, and that you can easily doing by simulate them. I see a hand up here. Dr. Sadiq Naveed, please go ahead. You have your hands up.
Sorry, I didn't have a question. I just was indicating that I'm here.
Oh, okay. Thank you so much. No problem. That's all fine. So what I'm trying to say, I will present a small data, which I did as a pilot data when I was doing my teaching scholarship program. And you have to do a small project. And this is kind of project I did, which started this whole movement of using simulation for quality and safety. It is here. You can see I did it in 2017 and 2018. There were 33 simulations that happened in 2017 and 12 in 2018. Total number of latent safety threats that we identify were 70 in number. And as for the time, I'm just a little bit passing quickly, and you can see it will be in all the areas, in medical management, in medication errors, equipment either not available or people are not aware what are they, resource and system related, and crisis resource management related. And what we did with all of them, we did like this is a study which is right now going on as a co-PI, where all the simulations are getting video recorded, and now we are just doing observation that how much simulation or how much latent safety threats are present in our environment, and they are all pertaining to medical management, pertaining to non-technical skills, any medication error. So this is one of the sim that is happening in the environment.
Today we're actually using it for research purposes. So we're videoing the team training to try to pick up latent safety threats. So the people that are going to see these recordings are essentially 4 people: me, JABEEN, Allison, and Jonah. And it's just for the research purposes. Once the research's done, then we get rid of these videos. So after we're done, we can just get you guys to sign a quick consent. Does anyone have any questions though? We'll be hearing a lot more of this. So again, I'll let you guys talk about anything like this. So safe.
I will just pass it on a little bit.
So I'm gonna have you do just a brief of how this is gonna work, just to remind you guys who haven't done it in a while. We also have our sim specialists here. Okay. Scenario say with my help. And then if you're successful with IVs, you'll just ask that, am I successful? And if you are, we'll give you 2 drains on either side. We want you guys to instill the medication to do it in real time. Okay? Questions?
Okay. So yeah, a 6-month-old girl brought to the ED by her parents. She's been vomiting, having diarrhea after several days. You're called because the patient is shaking. Yeah. Go ahead.
Okay. So Dr. Tess, you want to kind of do your arming assessment there? We have, parents in the room.
Yeah, we have all that. Yeah, it's making, dogs, like, lots of.
So I will stop it here. It will give you an idea. And these are all people who are either working actually in the ED or are there for their orientation. For example, a lot of nurses join and we make them participate in such resuscitation so they can get some benefit or some idea about how the resuscitation work, how to prepare medication, etc. So that's why you see a lot of people in there. And this is an example of direct observation being happening by an MD educator and a nurse educator. And you can see here with the time, everything is mentioned. And what is green is something which went well. And what is in red is something that needs some improvement. And we will talk about it in the debriefing. And you can see that it will go into Excel sheet and then it will go into which area they are working. Like, is there gaps in the medical management? Is it a gap in non-technical management? And you can see how much big process that goes beyond it. The second thing is people may be wondering that, oh, it is happening in simulation. So what does it have advantage? The advantage that we get by doing this, that we identify that our systems have a lot of potential errors, which are not reaching thankfully to the patient, but that is an opportunity, provide us an opportunity that we started working or doing acute event clinical debriefing. And what are those acute event clinical debriefing? That after we have 3 trigger points, after any cardiac arrest, after any trauma resuscitation that arrive in the emergency department, and then get admitted to OR or go to PICU or any neonatal resuscitation. We actually, after doing that actual resuscitation, the whole team sit together and they talk about, this is the format that they talk about, is 3 major themes. What went well in teamwork? What are the areas of improvement? And what suggestion do you have? I know some people get intrigued that, oh, they are so stressful, how they can talk about this when they come out of those resuscitation. It was initially a challenge for us, but then later on, people found it so valuable because they really want to get better with their medical management, with their teamwork, and provide the best care to the patient who have arrived to the emergency department. And by doing that, the good things or good action get reinforced and the areas of improvement get identified, and we start working on it in a huge, in a lot of ways that we were doing improvement. And the improvement is not only in developing the order sets, in educating the team, in making the other teams bring together. For example, we find out that when we have a neonate and we have to activate a neonatal activation team, that is not functioning. We collect the data and we found out that it took almost 10 minutes for the neonatal team to arrive to the ED. And we then revamp the whole process of activation. We test the process by doing simulation, and then our time of activation to arrival reduced from 10 minutes to 3 minutes, which is a huge win. And then during this kind of all these simulations, we also work on the handoff from ED team to the NICU team, which also bring the teams together, and they will realize that what are the possibilities that they can function in ED and what are the possibilities that they cannot function in the ED, and the patient need to be transferred to the NICU. I will take a pause here. I know I have only 10 minutes remaining here. I will take a pause and see if there are any questions, and I will move on to the global perspective, which I really want to showcase that how much work we have done with India and Pakistan by using the virtual or distance simulation. Any questions if anybody have?
Thank you so much. Let's just see. Yeah, Dr. Zed.
Yeah, thank you very much, JABEEN. We will continue. It gives me pleasure to introduce that we have Dr. Taimur and Dr. Sadiq Naveed, who are chair of APPNA MERIT and APPNA MERIT Research. I will request them just to say a few words because that's a really fascinating concept of having a simulation lab, and we can cross-fertilize this idea to many other specialty. So it's over to Dr. Sadiq Naveed. Unmute yourself, Dr. Sadiq, and please share. You are muted,
Yes.
please. Yeah.
Can you hear me, Dr. Uzair?
Yes.
Okay. So sorry, I'm in a very casual where I was actually covering, and I was lead alerted me that today is going to be last day. I think we have been doing this for last 2 years. We also published merit research report last year, which is available to the audience. So all of this has been possible because of the volunteerism of Dr. Uzair and Dr. Hasni. Both have been very actively involved in organizing sessions, especially Dr. Uzair and then Dr. Hasni moderating the session. I'm just a bystander. We arranged roughly about 21 webinars involving institutions and different organizations. And above all, I really appreciate Waleed's help, who is here appearing under the of this together and would not have been possible. Thank you to all the speakers and participants. I hope we continue to build on this process and make the change that is very much needed in Pakistan. Thank you very much. And
Thank
sorry
you.
for...
No
Thank you, Dr.
worries.
Sadiq Naveed.
Thank
Yeah,
you so
so
much.
we have,
Yeah.
Dr. Taimur Khan, please unmute Dr. Taimur yourself and please say a few words.
Yes, assalamu alaikum everyone. Thank you very much for giving me the opportunity to be present today, and thank you the merit team and Dr. Uzair for organizing it, Dr. Hasni moderating it, and all the participants. And per our data, I think the 120 plus attendants were there in almost all of these 21 sessions. So it kind of tells about the popularity of the APPNA webinars and the important areas that our team has been focusing on how to affect the research landscape in Pakistan by bringing the industry and the clinicians together and kind of bridging those gaps. So hats off to all the core members, the coordinator Waleed, and everyone who chimed in, gave their time. I was able to attend Dr. JABEEN FAYYAZ the most of the webinar today. Excellent talk, very impressed, and all these novel ideas are being brought to our broader audience in Pakistan, and their strength number tells us that even if it is 9 to 10 p.m. in Pakistan, people are chiming in, learning, listening, getting their CMEs as well. The one with the CME accredited and the one non-CME accredited, they are for knowledge purposes interacting and learning from this vibrant question and answer sessions. So thank you everyone. Hopefully, inshallah, we'll continue this momentum to next year as well. And I thank you all everyone for giving and sparing their time and valuable resources pulling into this dynamic APPNA webinars.
Thank you so much, everyone. I just want to take 5 more minutes or 7 more minutes. Is it okay?
Yes, please
So
go
I
ahead.
think, so Dr. Jabeen, I just want to say something is that we only have 6 minutes left. So please go ahead and take it, but I don't think that we would have time for Q&A after that. So
Okay,
if you,
I just will quickly go through this or maybe show a video and then I will stop it. There are 2 questions here in the chat. One question is, are these courses are available? Yes, these courses are available. We are doing it a lot of them from the various platforms in Pakistan, and there is a plan that we will start doing it from APPNA platform. And then a level of learner. Yes, every course is for different level of learner. For example, whether it's a skill-based, whether it is for interprofessional teams, or it is just a basic level. So there are definitely different level of courses which are present for different level of learner, and you can definitely reach out. I would say we will definitely reach out to you or publicize it through the APPNA platform whenever these courses are announced. So I will just skip these slides and maybe I will get a chance sometime to go through them and I will show you this video.
My name is Dr. Saima, and I'm one of the consultants at the Department of Emergency at the Indus Hospital, Karachi, Pakistan. Working in a country with a population of more than 200 million and based in a city which is the 5th most populous city in the world, our challenges are numerous. From overpopulation to underprivilege, from lack of basic healthcare facilities, leading to untoward events, lack of infrastructure, lack of manpower in healthcare, and the recent pandemic with urban flooding. Our challenges are numerous.
Here at the Emergency Medicine Department, me and my colleagues, we aim to bring about change in the emergency care delivery by training young aspiring EM physicians in terms of clinical research with evidence-based training programs inculcated with simulations.
These challenges are what make us strong. We face them together as a team through our resilience, through our capacity building, through our focus on the future, through training our future EM physicians. And we strive for it every day.
So I'm very proud of saying that we have done multiple trainings in Pakistan with the Indus Hospital, where we are not only training their EM residents for pediatric emergency medicine. We have started a 1-year certification program in pediatric emergency medicine, and the first cohort has just graduated in July, and there were 23, which are all over Pakistan. They are all simulation based, and then we are running the second cohort. We realized that faculty development is a kind of challenge. So we have started a simulation instructor workshop, and we have done up till now 4 versions of hybrid versus in-person versus totally simulation-based simulation instructor workshop. And we have trained almost more than 60 plus faculty member in providing simulation-based teaching and learning. I'm in conversation with the University of Lahore, and we got initial approval to develop this or start this certification course with the for the simulation like certification course. And the plan is to make it a mandatory course in the master's and the Ph.D. of health profession education. Last 1 minute is like we have recently in last month, I was in India, and we have worked on implementing this national trauma resuscitation program, which is kind of a counter version of adult trauma resuscitation program, and trained 72 faculty member there for trauma resuscitation by utilizing simulation. And as I said, the simulation is a growth and a continuum. You will keep on going talking about it, utilizing how to utilize and where to utilize. But I know the time limit is there, and these are my contact details for all of you. I know I'm not able to take a lot of questions, but I have already discussed the two first question, and in cancer treatment and in Toronto join. Yes, for sure. I said already in the beginning, anybody who want to join, come to our sim center. Definitely, I can facilitate that. And there are possibilities of observership, elective, and also assimilation fellowship as well. Please feel free to reach out.
Thank you so much, Dr. Jabeen. That was very insightful, and I think people learned a lot from your talk. So, and thank you so much for sharing your email and providing the contact information. So, Dr. Ozair, do you have any comments?
I would just say, because fortunately we had Dr. Taimur and Naveed Sadiq, and they are already spearheading a lot of capacity building activity from APPNA. And, this can be a cross fertilization. It's a very cost effective. And, there are many, very, very, what I call it, straight confession as a senior faculty that how resistant are we to learning, and sometimes we feel shy. In this way, this is a cross fertilization. So we are extremely thankful to Dr. JABEEN FAYYAZ, and we look forward to maybe having a series of such webinar, maybe on a family physician or pediatric physician forum. So thank you very much to you and the participant, and the technical team, and Dr. Akhtar, Dr. Sarfraz. So with this, I think we are just close to the time. So once again, thank you to everybody. And Dr. Sarfraz, last word if you would like to say, and then we say goodbye to everybody.
No, I think thank you so much. I think this was a phenomenal session, and I've learned a lot from this, and I see with the how the audience must have learned a lot too, obviously, and the enthusiasm that Dr. Jabeen has showed definitely shows that she's very passionate about this. So thank you so much for this informative session. And as a reminder to our audience and those who were not able to join it today, is that we have the recordings available at our YouTube channel. So you can always listen to that, and it goes without saying that all of this will not be possible without the technical support from Waleed and his team. So thank you so much, and we will see you all in another 2 weeks with another topic on APPNA webinar. Thank you.
Yeah, thank you everyone, especially the leadership and the technical support and everyone. I really appreciate, and I hope this will continue.
Thank you. Okay. Allah Hafiz. Bye.
Allah Hafiz. Take care. Bye.